Our next speaker now is Dr. Mary Donnelly, who has been to virtually every university on the island and others beside, and has degrees from them all. I cannot understand why she's left out Northern Ireland, but there you are. Mary, the enterprise train is good, and the connections are better, I'm sure, from Cork than they used to be. She has written a publication which I haven't read, but certainly will, I can tell you, Consent, Bridging the Gap Between Doctor and Patient, because we get so much of this that as a doctor you smile. I did medicine because I was in hospital 16 times before I was 16, and I was determined I was going to stand beside the bed for a change and not lie there with someone looking down at you and telling you what to do. So that's the sort of medical model I remember. So consent is a very interesting thing where the medical profession is concerned. So we're very honoured now to hear Mary talk about treatment and condition, a human rights perspective.
Right, good afternoon. It's very nice to be here, and thank you, Darius, for organising this wonderful conference. As you can see from the title slide, I'm going to be talking about treatment and conditions from a human rights perspective. I have two things which I'm hoping to draw out during the talk. First, to elaborate a little on a point which has been coming through, I think, throughout all of the talks today, and that is the role of voluntary patients and the concerns we need to have about voluntary patients. The second issue which I'm hoping to explore is the contribution of human rights discourse to developing and improving treatment and conditions. And as certainly the lawyers among you will know, we've seen quite a number of liberty-based applications to court. We've seen very, very little activity in terms of treatment or conditions. And I suppose I'm trying to throw out some ideas regarding potential in that respect. In that regard, I'm going to be relying quite a lot on European Court of Human Rights jurisprudence and hopefully exploring some of the implications of that. So just briefly to tell you what I'm going to be doing during the talk, I'm going to do a brief background, going to look again relatively briefly at the legal framework set out in the Mental Health Act, because I know Patricia is going to do that in more detail. And then I'm going to look at this issue of voluntariness and how it impacts on issues of treatment and conditions. And then I'm going to look at changes since the introduction of the Mental Health Act. And Hugh referred to the resources which the Mental Health Commission provides, and they are genuinely wonderful. We are really getting a flavour of what's going on, which we really did not have until the establishment of the Commission. And I would heartily encourage people to engage with that literature. I'll be drawing on that to an extent. And then I'm going to talk a bit about using human rights instruments. I'm going to look briefly at the CRPD, the Convention on the Rights of Persons with Disabilities, which I know has been mentioned on a number of occasions, but my main focus is going to be on the ECHR, because I hope we may be in a position to actually make some arguments before some courts in respect of that. So I'm going to just have a couple of slides on background. And in a sense, what I want to do is to contextualize the discussion. One of the things we'll see is a movement away from physical treatments to medication. It's absolutely essential that our rights framework follows that movement, that we are aware of the consequences of medication. It is also important to be conscious of the history of abusive treatment practices and its implications for how people respond to the mental health system. And any of you who have followed the letters page in the Irish Times, the debate in respect of electroconvulsive therapy, will see very, very strong views being expressed by people on both sides of the equation, I might add, people from both sets of perspectives. One must also note that medication has therapeutic benefits, and I'm certainly not suggesting other than that. Couple of other points to note here, and I think Diarmuid made them far more eloquently than I can. The lack of resources in terms of alternative to traditional medical treatments. Diarmuid raised the issues. If you look at Elizabeth Dunn's excellent study of service users, again published by the Mental Health Commission, you see a very strong message coming out there. People are saying we can live with medication, we can accept medication, but we want more. We want access to psychotherapy, we want talking therapies, we want access to a range of treatments. And you see, and again Diarmuid pointed this out, you see a lack of that kind of access for people. And finally, I suppose, it is important to be conscious, and I think both previous speakers noted it, the role of stigmatization. People, because of the stigma which goes with mental illness, do not necessarily feel comfortable seeking help. As a result, they do not get access to the treatment they need at the time they need it. In terms of conditions, that old theme of lack of resources comes up everywhere you look. Again, wonderful information from the inspector's reports. And I'm just going to draw a little bit, just to give you a flavour of what we're talking about. Going to draw a little bit on the report which came out last year in respect of the Tipperary Mental Health Inquiry. Just to give you a few quotes from that report. The inspector found a lack of individual care plans, inadequate records. Psychiatric reviews were not based on comprehensive needs assessment. Seclusion was not always used as a last resort. Poor ward design, low staffing levels. One of the units investigated, residents had to wear their night clothes during the day. People were described as being on parole. These were not detained patients, but they were described by staff as being on parole. No policy governing locking of wards. Decor, for what for many people was their home, was bare, monotonous, bleak. One dormitory had no curtains. Lack of showers, lack of baths. There was also a pattern of undetected fractures, and it was not clear how or why these were happening. The Inspectorate's report on St. Ita's Portrane, some of you may have seen this recently. You'll see the quote, direct quote there, "It's difficult to convey the extent of dilapidation of the hospital building." That incidentally is the hospital building up there. Again, I'll just give you the description. Long corridors in poor conditions, toilets with no privacy, paint peeling, mould in showers, broken furniture, ill-fitting doors, cramped dormitories, the smell of urine, poor ventilation and a bare, drab environment were clearly evident. Final issue I want to raise with you is the conditions in which prisoners with mental disorders are held. Central Mental Hospital did a recent study of 615 male prisoners on remand. 47% of those people had had contact with psychiatric services. 3.8% of them had significant psychoses which were increased by their time in prison. Now, how does the Mental Health Act deal with this? Mental Health Act is linked, it's a framework for treatment, it's linked to admission. There is no provision for community-based treatment. It applies primarily to involuntary patients, and certainly in respect of treatment, most of the measures apply to involuntary patients. And as I'm sure many of you know, the application of the Mental Health Act is based two criteria. They're alternatives. Risk-based application, somebody can be admitted on the basis that they pose a risk to themselves or others. The alternative basis for admission is that there is a therapeutic benefit to be gained from admission. I'm not aware of any data on how that breaks down in terms of what bases are being used. You may have data, but I've not been able to find any. Now, we had a discussion earlier about the principles underlying the Mental Health Act, and I've just sort of summarised them up there. Just to give you my tuppence halfpenny on best interests, One thing which is worth remembering is increasingly, particularly if you look to England and Wales, you'll see a definition of best interest which incorporates the views of the individual. It's an attempt to, I suppose, marry, coming back to the point made earlier, to marry paternalism with participation. How well it will work is something we have to wait to see, but there is an attempt to provide a definition of best interest which goes beyond your simple objective paternalism. Principles are good things. I like principles, we all like principles, but principles don't put butter on the bread or whatever. Principles are excellent things, but they do not necessarily solve all issues. So therefore we see these principles, they are very worthy, they are very worthwhile, but ultimately they are limited in what can be achieved. Now Patricia, I know, is going to talk more about the framework for consent and the provision of treatment. I've represented up there in summary form the role of consent in respective treatment. And in looking at that slide, just bear in mind there's another one coming which kind of changes the picture a little. There is a requirement for consent unless a person lacks capacity. But the person who decides if a person lacks capacity is the psychiatrist who decided they needed the treatment in the first place. There's no review mechanism for that provided in the legislation. There is something which I think is very worthwhile in the legislation, a requirement that information be provided, and you can see there, in a form and language the patient can understand. That's very laudable, but there's no enforcement mechanism. There are also additional tribunal requirements regarding psychosurgery. We don't see psychosurgery happening, so therefore it's not an issue for present purposes. That's your first part of the framework. Your second part of the framework for treatment, however, is certain treatments may be given without consent. We've talked about ECT, the issue has been raised already. Electroconvulsive therapy may be administered to a patient who is unable or unwilling to give consent. Similarly, ongoing medication, i.e. medication for more than 3 months, may be administered to a patient who is unable or unwilling. In both cases, there is a form of protection. The form of protection is a second opinion. It is not an independent second opinion. And it is very definitely not an independent second opinion because the statute says, the Act says, that the second consultant psychiatrist is chosen by the patient's consultant psychiatrist. So it's in a sense statutorily precluded from being independent. Now, in respect of voluntary patients, very briefly, voluntary patients are governed by the common law rules, and they centre on this concept of capacity. Person has a right to refuse treatment if they've got capacity. If they lack capacity, treatment can be given to them on the basis of their best interests. No review mechanism provided for in respect of capacity, but perhaps more significantly, for these patients, there's no review at all. Not only not an independent second opinion, but no second opinion at all. Now, just to talk briefly about the realities of voluntary status. Now, some of you may be familiar with Mr. Justice Kern's decision in EH. And he noted voluntary means something different when we look at the Mental Health Act to what it means when we talk about things normally. Voluntary in the context of the Mental Health Act means a person who isn't formally admitted. The realities of voluntary status is you will have a number of people, and I can't give you numbers on this because they don't exist to the best of my knowledge. You will have numbers of people who agreed to be admitted to avoid compulsory admission. You have the possibility of regrades. There were 584 regrades, in other words, a change in status from voluntary to involuntary, 584 in 2008, I think it was 590 2009. You have people who lack capacity and who are simply going along with things. Again, I don't have data. And you have long-term patients. The most recent data I could get on this, in 2006, the Mental Health Commission report, 46% of patients over 65 had been 5 years or more in that facility, in the approved centre. But those people, in many instances, had nowhere else to go. Now, in terms of conditions, the Mental Health Approved Centres regulations apply to all residents. And one of the useful things about them is they require an individual care plan. We'll talk more about that later. There are also provisions, you can see them there, you can read them, I don't need to read through them for you, but basic provisions governing the conditions in which people live. In respect of seclusion and restraint, there are rules governing the use of seclusion. New rules, incidentally, have come into force. They're effective from January. There's also a code of practice on physical restraint. There is no provision on chemical restraint. What's chemical restraint? It's the use of drugs to prevent movement, essentially, forms of sedation. Now, just to give you a flavour of how things have changed since the Mental Health Act was introduced, the big thing you'll notice, and I hope you can see that there, your involuntary admissions has been coming down. So fewer people are admitted involuntarily, which means probably you are seeing more people as voluntary patients. Now, a lot has been said and about ECT and the issues to which it gives rise. I know there's a bill going through currently. Hugh has referred to it. Worth noting, though, current usages of ECT. Primarily, ECT is used for voluntary patients. 80% of ECT is used with voluntary patients. In respect of involuntary patients, so you can see there, 12% of ECT is done without consent. Mental Health Act Commission analysed the Form 16s, the relevant forms, in 2008, and you'll see how that breaks down. Most instances in which ECT was prescribed without consent concerned patients who were unable to consent, and you'll also note in 11 instances patients were unwilling, and you'll also note a split in opinions, rather a limited split in opinions. Most of the time both consultant psychiatrists agreed with each other in their assessment. More difficult to assess how medication has changed and medication practice has changed. However, the Inspectorate, the Mental Health Inspectorate, has done some very worthwhile work. They find a wide variation in terms of the clarity of prescriptions, in terms of the accuracy of prescriptions, and in terms of the descriptions of the patient and the drug. The very valuable study in the 2008 Act, or 2008 report, I should say, on the use of, and excuse my pronunciation here, benzodiazepines. I've been practicing that over there for ages, and I'm sure I got it wrong. Royal College say, these are anti-anxiety medications. Royal College of Psychiatrists guidance say these should be used rarely and for a limited period. The Commission found they were being used in, as you can see, 63% of inpatients, more than one, 43% in acute units, 37% in long stay units, and typically without time limits or review. In terms of communication, participation, consultation, all these things that show up as important. Most recent study, which is a very valuable study from the National Service Users Executive, 58% of service users felt listened to, 57% of service users felt they were treated with dignity and respect. As to whether that constitutes a change, just to give you Elizabeth Dunn's work back in 2006, which was done just before the commencement of the Act, service users identified problems with communication. And essentially they said, we can take medication, we will take medication, but we want to know the side effects. We want to know what we're agreeing to. In terms of changes in conditions, the one I want to really draw to your attention there is in respect of individual care plans. It's the one on the left there. You'll note 84% of approved centres self-assessment. In other words, they thought they were doing this. 84% thought they were doing individual care plans. You'll note the inspector's finding, 18% were found to be doing and using individual care plans. 33%, that's an improvement obviously, but certainly not a dramatic one. Mental Health Commission's most recent report disappointing progress on compliance with rules, codes and regulations, but some tentative causes for optimism. And it is important to be conscious of these. Inpatient with Victorian psychiatry may be reaching critical mass. Okay, let's talk briefly about using human rights instruments. I'm going to skip away from the convention. We need to have the convention ratified. The ratification of the convention is very, very significant. It can make a genuine contribution. My focus, however, is going to be on ECHR law. I'm going to skip this slide and move on to talk a little bit about freedom from inhuman and degrading treatment. It's an aspect of the right to dignity. It's protected under the Constitution of Ireland. It's also protected under the ECHR. The classic difference between the two is the ECHR does not require an intention to degrade. Before the right applies, there must be a minimal severity standard must be reached. In, I suppose, the leading mental health case, Hertzgefalvi versus Austria, the European Court of Human Rights, and incidentally it had no difficulty holding that the forced feeding of someone using security beds, which involves several broken ribs, reached the minimum severity standard. However, the European Court of Human Rights said, where treatment is therapeutically necessary, it is not considered to be inhuman or degrading. Having said that, however, the court said, however, it must be convincingly shown that that treatment is therapeutically necessary. It's not just enough to say it, it must be convincingly shown. In other words, you need an appropriate and an adequate review procedure. The other thing I want to draw to your attention in respect of Article 3 is that the European Court of Human Rights has been broadening its application. And in particular, it has been recognising the possibility of positive rights. To draw a couple of cases to your attention, both have concerned prisoners and the conditions in which prisoners with mental illnesses were being held. But in two cases, Keenan versus the United Kingdom and Ibecu versus Albania, the court held that the conditions within which a mentally disordered or mentally ill prisoner was held were sufficient to amount to a breach of his Article 3 rights. The court, and just to give you very briefly the relevant quote, the court held, treatment of a mentally ill person may be incompatible with the standards imposed by Article 3, even though that person may not be able or capable of pointing to any specific ill effects. Other right I want to draw to your attention is the right of autonomy. Any imposition of treatment on a person with capacity is a breach of their autonomy. The right is not absolute. The right can be overridden. There is nobody who will tell you the right is absolute. It is overridden in the mental health laws of many jurisdictions. But, and yet again I come back to this notion, it can only be overridden where it is absolutely necessary to do so. And one of the things, again, we see coming out of the European Court of Human Rights is this notion of autonomy as a positive right. In other words, not just a right to be left alone, but a right to be empowered. Leading case, Tysiak versus Poland, was concerned with a right. In the case in question, it was concerned with a right to lawful abortion under Polish law, abortion in circumstances in which it was lawful. But what was striking was the European Court of Human Rights was very critical of the failure of the Polish authorities to give a process or a procedure or a way for the woman in question who wanted to assert her right to actually do so. The decision as to whether or not someone could or couldn't have an abortion, it was a medical decision, and it was made simply by one medical doctor with no right of appeal. court said that's not good enough. That does not protect autonomy. Final right I want to draw to your attention and talk about briefly is the right to bodily integrity. Now, I'm quite fond of this right. I think this right has a lot of potential, mainly because it's not capacity-based. Why am I so concerned with the fact it's not capacity-based? Because I think it's terribly important to be conscious of the fact that people, and I think actually Baroness Hale, as she now is in the House of Lords, describes it better than I can. She said, most people are able to appreciate that they are being forced to do something against their will, even if they are not able to make the decision that it should or should not be done. Again, the right to physical integrity, the right to bodily integrity is not an absolute right, but it is a right which cannot be interfered with without a just and reasonable cause. Once again, we have this issue. Can interference, can the imposition of treatment, and you'll see there the reference to a very significant decision of the European Court of Human Rights in the case of Stork versus Germany, concerned a young woman, incidentally, who was brought to a private psychiatric facility in Germany as a young woman. She was held there for many, many years against her will and treated against her will. The court held her right to liberty was breached. They also heard her right to bodily integrity was breached. It didn't matter whether or not she had legal capacity. The court weren't concerned with that. They were concerned with the fact that treatment was imposed on her against her will. And you can see the quote, even a minor interference with the physical integrity of an individual must be regarded as an interference with the right to respect for private life if it is carried out against the individual's will. Very briefly, practical implications of these for Irish law. First off, I think we need to look much more closely at the role of restraint. I think we need statutory guidance on restraint. I think we need a stronger statutory statement in respect of restraint. The second thing which I think we need in order to comply with the European Convention on Human Rights is we need a better basis or formula for reviews, both in respect of treatment and capacity. We don't have an independent review in respect of medication. We don't currently have an independent review in respect of ECT. We have a very limited right to a second opinion. It arises only in respect of involuntary patients. And yet I've argued that voluntary or voluntariness is something which we really must question. We have very, very limited protections for voluntary patients. And I might add as an almost final point, we have very limited protections for consenting patients. I think we need to think very much about this notion of consent. Most of us think, oh, people are consenting, well, that's fine. Mental Health Act Commission in the UK, in their 13th biennial report, offered the following insight. And again, like our own Mental Health Commission, these are wonderful resources, and sadly they've now been disbanded, so they're now coming to an end. But here's their comment on consent. We have no doubt that there are many patients who throughout their detention are erroneously described as giving consent to their treatment, mainly because they have been asked to agree to treatment without it being explained sufficiently to allow for informed consent, but also because of unrecognised mental incapacity or refusal. So sometimes people are refusing, but that message, according to the Mental Health Act Commission, which fulfills a similar role to our inspectorate, that message isn't necessarily getting through. Reform priorities, everybody is saying it, we're all singing the same song. We do need capacity legislation, and I know Patricia's going to talk further about that, but I think we need more. I think we need to address the particular human rights concerns in respect of patients with mental disorders. I think we need to gather more empirical data regarding what is actually going on. The Mental Health Commission does a very good job, we need more. I think we need better reviews of medication. I think we also need capacity building, empowerment building. Autonomy is something positive, not just a right to say no, but an empowerment mechanism. And I would like to see an increased role for positive rights, particularly in respective conditions. There is, I think, scope for developing the law and developing legal engagement in that regard. Thanks very much.